I'd like to introduce the topic of big issues for ACO policy going forward. Some of the main topics that we're going to discuss here build on the discussion that you've already heard. We've heard about the state of the evidence on accountable care and about some of the key issues and challenges facing accountable care organizations on the ground. Now we're going to turn to the potential policy and regulatory reforms to help address these challenges. Obviously, some of these topics have already come up today, but just to help get the discussion going, I wanted to highlight a few. One of them is the issue of the benchmark and payment systems. We've heard about some challenges around how the benchmarks are calculated, whether those savings are retained over time or go into a new base, how attribution works. We've talked about transitioning to more person-based payments that are more at the person or capitated level. That means more significant financial risk, but it's something that many ACOs seem ready to take on. We've talked extensively on this last panel about steps and policies that could support increased beneficiary engagement. Issues related to performance measures have come up, both performance measures that are less burdensome to report, but also measures that could be more meaningful for capturing issues like underuse of care and more meaningful patient-reported outcomes and the like. We've heard about challenges related to data availability, since timely, comprehensive data is really critical to many of the steps to improving care, being targeted and having an effective impact. We've talked about some of the other payment reforms going along with accountable care organization payments that can potentially reinforce their effects. We've talked about steps to overcome startup costs through things like bonus payments and other incentives, and we've highlighted the challenges of actually implementing effective reforms in clinical care and how opportunities to share experiences and research on what really works to improve care and lower costs in particular kinds of healthcare settings and markets today can be very important. So plenty of opportunities for further discussion, debate, and hopefully constructive next steps on the policies affecting the ACO programs in the country, and particularly the Medicare ACO programs. A very timely issue right now with the upcoming regulations and further payment and regulatory reforms that are coming. And we've got a great panel to discuss these issues, so I'd like to introduce them briefly now. Starting on the far end is Mark Wagar, the president of Heritage Medical Systems, which is an affiliate of the Heritage Provider Network that serves over 1 million patient members in integrated population-based programs through medical groups and independent practice associations in California, New York, and Arizona. Heritage Provider Network also manages one of the largest pioneer ACOs in the United States, and one that seems to be doing quite well so far in the Pioneer program. Next, I'd like to introduce Joe DeMoore, who's Vice President for Population Health Management at Premier. Joe has extensive experience in leadership roles for successful hospitals and health systems, including 19 years as a hospital and health system CEO. He's successfully developed several integrated health systems, and his expertise includes strategic planning for hospitals and integrated care systems, financial and operational management, governance and leadership development, business planning, quality enhancement, health insurance plan, and ACO development, and physician-hospital integration. No shortage of skills needed for success in these kinds of healthcare reforms. Next, I'd like to introduce my longtime colleague, Mark Miller, the Executive Director of the Medicare Payment Advisory Commission. MedPAC is a nonpartisan federal agency which advises the U.S. Congress on Medicare payment, quality, and access issues. Mark came to MedPAC in 2002. Has it really been that long? Where he previously was at the Congressional Budget Office as Assistant Director of the Health and Human Resources Division. Before that, Mark Miller was the Deputy Director of Health Plans at the Medicare program. And last but not least, I'm very pleased to introduce Paul Ginsberg. Paul's a Norman Topping Chair in Medicine and Public Policy at the University of Southern California, and also a fellow here at Brookings. From 1995 through the end of 2013, he was the president of the Center for Studying Health System Change, and prior to founding Health System Change, Paul served as the founding executive director of the Physician Payment Review Commission, now part of the Medicare Payment Advisory Commission. As with our last panel, we're going to start out with some opening comments from our distinguished panelists, and then turn to a further discussion of some of the policy issues and potential solutions on the horizon. So, Mark, let me start with you.
Sure. Thank you, Mark. Heritage is probably at the other end of the spectrum from many people in the audience and participating in the ACO program. So of our 1 million patients, 800,000 are fully delegated, completely capitated. We pay the claims, we do the care management. We have almost 3,000 physicians in medical groups that are employed. We probably have 30,000 contracted physicians, primary care and specialty and independent practices that surround those. So we try to focus on concentrating in markets and presenting a delivery system that can actually produce differentiated results. Our success in the Pioneer, I think, is primarily driven by that experience that was referenced earlier. So Dr. Merkin has been at this since the 70s, been through all the ups and downs of different versions of managed care. And we were able to extend in the ACO, the Pioneer ACO program, all the internal things that we do for those prepaid populations. So, you know, the independent practice that was a first-timer to the ACO, you know, gets the social worker who's going to work with the family, gets the community care worker, gets the Meals on Wheels. I was pleased, by the way, to hear the conversation about consumers. Because we have about 30% churn. That sounds familiar to a lot of people out there. And number one is, how do you financially survive that? But number two, what we're finding, given that we've had some success and we've taken the education road with consumers, so we found they didn't know a thing about it, didn't understand they were in it, so we had group meetings not to market, they're already in the program, but we're a part of your physician office. If it's the patient or the family member who often accompanies them, here's what we've added to your physician's office capability. Then when they get moved by whatever attribution mechanism, they're calling back and saying, well, why am I moved? You know, I liked the social worker who was working with us and take care of mom or what have you. So that's a challenge. I think you know, the secret to our success, like the Hackensack system, we spend money that we make elsewhere to try to demonstrate that this program will work. It ultimately, like all the organizations that are participating, if we don't evolve the payment mechanism to something more population-based, it will run off the cliff. So the big organizations like us, or hospital systems or what have you, other big medical groups, we may have the staying power to stay with it a while longer, but if you don't end up doing something other than like the rural thing, effectively what was done when you give money in advance for providers who don't have it, and then you have to give it back out of your savings. That's reverse capitation. Okay? That's what we have in advance. And we don't have any argument about whether or not you need an air conditioner, or whether or not you need a ramp. We don't have to look up the benefit design. You know, the answer to access is, could you come in this afternoon? If you can't come in and you don't have anybody to bring you, we'll go get you. If you can't come at all, we'll send somebody to see you. You know, we think with all those providers and hospital relationships we have, we're great at taking care of people when they present and need care. But more importantly is, can you find them before they present and they're sick enough or injured enough to fall in the door, so maybe they don't need care, or they need a different kind, or it's not as intense. So we We think the program is a great learning ground. I think we've proven that with the independent practices, but we want to see what happens next and be an advocate for the change that's coming.
Great. Thanks. And please go ahead, Joe.
Great. I work with a team of people in population health management who work all over the country. We've worked in about 150 markets in the last 3.5 years, helping organizations transform into population health. On the Medicare side, we've worked with pioneers and MSSPs, probably over 50 of them. On the commercial side, we work with a lot of the major commercial payers, Blue Cross plans across the country to build new models. We work with Medicaid programs, for example, putting in DSRIP programs across the country. So we work across the entire continuum. And what I'm going to try to do is just summarize how do our people feel about it, including with Maury's organization at Hackensack. And I would just add that one other thing. Our organizations that we work with have done much better than the national average in regard to hitting savings rates. Like Hackensack, they've done a great job, and we've got a lot of others that have done well. I think almost 80% of the organizations we work with hit their minimum savings rate in year one. So not all of them got shared savings, but a really high percent hit their minimum savings rate. And we like to think it's because the exhaust from the success we share with each other. We have a collaborative that allows us to share with organizations what's working. And then the second thing we really try to do is stage what you build. Because what we find is many organizations try to do too many things too early. And what we've learned is stage them over time, and there's a staging process that we think works. So our experience has been, number one, on the MSSP and Pioneer side, people need accurate, timely data, and we're still not there yet. And it's kind of like flying a 747 without an accurate instrument panel. If your attribution changes 30% in a quarter, it's really difficult to get an accurate denominator on all of your quality metrics, your financial metrics. So we've got to fix that. We have to fix that attribution issue in this next round. And then on the top line, if we don't have accurate claims and timely claims, you really can't manage on a day in and day out basis. So we need to fix that. So data is really critical to be successful going forward. Second is there's a number of areas in the economics that need to change. For example, the minimum savings rate issue. As I said, we have so many organizations that hit their minimum savings rate, but what happens next year, it's dialed back to zero again, and that doesn't make sense. So somehow that you should be able to take a credit for the success this year and carry it over towards your target for next year. It seems terrible to say, well, you did pretty good this year, but you didn't hit the minimum savings rate, but you're going to start all over again. That doesn't make sense. So we think those kind of things need to change, and I can give you more and more like that. The risk adjustment process is not really sound in our opinion. The benchmarking and the metrics need to be realistic and setting it in their targets rather than saying you got to hit 100% of some of these metrics in order to get full shared savings. The third area would be, where do we think we need to go? So number one, we think we need to allow organizations to continue the one-sided risk model for several reasons. One is if they don't have totally accurate data, I don't think it's appropriate to go to two-sided. That doesn't make sense. But also there are organizations, and I think that there was a great summary earlier about the types of organizations in MSSP. There's a lot of organizations that are in risk for the first time, and I think it's too early for them to go to two-sided risk is our experience. Second, there are organizations that are ready to phase into two-sided risk, and they should be given the opportunity to, in that model, to maybe go to track 2 and phase it in over time. The third is we do have a small number, as Mark pointed out earlier, of organizations that want to go to full capitation or a full global payment, and they should be given that opportunity. And the fourth, we've got a couple that would like to go into full capitation plus Part D. So we see those 4 options as a prudent way maybe to offer the current MSSPs the ability to stay involved, make decisions that fit their market and their organization. So we're hoping that CMS will come through with something like that. So I hope that makes sense to you.
Joe, thanks for the comments. Mark, I know MedPAC has extensively analyzed these issues and has a number of recommendations already, and looking forward to hearing from you.
Yeah, and I think there's some overlap with what you...
We have talked in the past.
We've met. So there's a couple things. We spent the last year and a half talking to ACOs, site visits, case studies, surveys, and lots of people who rolled through the office to talk to us. And we put together a set of short-run comments, which I'll go through, and then we started talking about what the direction is for the future. There's two products. I have to mash it into 5-7 minutes here, which I will do, but there's two products you should keep in mind. There's a June letter that we wrote to the administrator, and obviously we're always writing to the Hill staff when we do this, and that's up on our website. And then also our June 2014 report talks about some of the future stuff. From the comment letter, we were trying to make comments based on things that we had heard from the field that we could also reconcile with the, taxpayer and beneficiary interests on the Medicare side, and we made a series of recommendations for the next round of the ACOs. And on the issues of attribution and the prospective benchmark, which is already, or the benchmark, which has already been mentioned, we made the argument that both of those need to be on very clear and consistent prospective basis. So whether it is set up to be retrospective, your attribution changes during the course of the year, or the benchmark changes during the course of the year, or whether there are methodological issues that effectively change the benchmark as you're going forward, that shouldn't be the case. The benchmark and the attribution should be on a prospective basis. There's a certain stability and just a predictability that we think will allow the ACOs to manage better under those kinds of circumstances. Now, there's much more detail on how to do that in the letter, but the basic issue is attribution and benchmark on a prospective basis. A legislative thought just on the side, but just to get it out, is that for attribution purposes, advanced practice nurses, nurse practitioners, PAs should be part of the attribution process. And again, that requires a change in law. And again, I won't get into this because it's much more complicated than 5 minutes, but there's a specialty attribution process that we have talked about changing. And we would say the ACO should be able to designate certain specialists who are engaged in relatively primary care types of activities, like when you're going to your cardiologist because you have a heart condition, that type of thing. Again, there's more detail, but just to blow by it in less than 5 minutes. The next thing is that I would say was a big deal in our comments is the quality indicators. Throughout this process, we made the point that there were too many and that they weren't particularly the best ones, at least in our judgment, that should go. And we were concerned about the administrative burden and actually just some of the measurement issues. We heard very clearly from the ACOs that this ended up being a lot more resource intensive than they had anticipated. And we have argued pretty consistently through this process, not just in ACOs, but in MA and fee-for-service, for a smaller set of population-based quality measures. And so we made that point again. There's more detail, more complexity, but you can look at the letter. We do want to encourage movement to two-sided risk. We know that there's some reluctance and concern about that, but we do want to move to two-sided risk, and there's a couple of connected thoughts here. One is we heard a lot of concerns, and some of it was echoed in the previous session and right here, about the notion of being able to engage the beneficiary better in order to kind of get the leakage issue under control, and also just to engage the beneficiary in their care. We made a recommendation that if the ACO is willing to accept two-sided risk, they should be able to forgive cost sharing for the primary care visit for the beneficiary. In this way, some of the way you explain the ACO is rather than explain, here's an ACO, here's how it works, which lots of people, it's hard to understand, is to say, look, if you go to your primary care physician, there's no cost sharing. You kind of get them in and manage from that point. And then there's people who should know how to manage from that point. And then the other thing we said is that if you accept two-sided risk, there should be some regulatory relief, that lots of rules in fee-for-service are about kind of curbing the fee-for-service volume-oriented behaviors. But once the risk shifts to two-sided risk and some actor has said, I'll accept the risk, then a lot of that should fall away. And we gave examples of where we ourselves, and the rest of the community should start focusing on regulatory relief to roll back. We heard lots of comments from the ACOs wanting to talk about an enrollment model, a capitated model, which I think involves more discussion, and also on other ways to engage the beneficiary. And in wrapping up, the June 2014 report talks about the future and how the ACO kind of fits in the large picture. Now, this gets a lot more complicated and a lot less clear, but the point that we're kind of driving to is the notion of a single unified benchmark that says for fee-for-service, ACO, and MA, the government may have a support rate. And then within a given market, whichever model can dominate or be a strong player, that model can come forward. And some of our concern here, and this is the last comment, is MA plans have a lot of overhead. They have enrollment, they process claims, they do that type of thing, and you may not have enough utilization in a market to finance all of that and still make a profit. And an ACO might be a model where you have thinner utilization and you can capture 1 or 2 points and make that model work relative to MA and fee-for-service. Now, I know it's a lot to throw at you, but that may be on question. We can talk that through.
Mark, thanks for covering a lot of ground in a few minutes and also giving people the references. Paul?
Sure. I'm going to try to avoid repeating some of the things said, which I agree with, but let me just start out saying I think the ACO is a very promising concept, and I see the concept as providers taking a moderate degree of performance risk to lower the trend in spending per attributed beneficiary and to improve measured quality. But good concepts cannot overcome flawed details. And the Medicare ACO models have been important catalysts for ACOs becoming a significant part of provider payments. But I think the shortcomings in the details are becoming better understood over time, and this is the time to fix as many of them as possible. My sense is that the ACOs have been tolerant of these details in the model as long as risk is one-sided. But the prospect of two-sided risk, which is important to get to, has really raised the pressure to resolve the problem. So it's not just the organization's capability of taking two-sided risk, it's their confidence in the model and whether they're actually willing to risk a loss on a model they don't really believe in because of the details. So I think the nation needs an effective ACO model for its most important payer, which is Medicare. So I won't repeat, I'm in agreement about comments about patient attribution, beneficiary attribution, that ACOs need to know who they're responsible for, and they need the ability to reach out and engage them. I had a couple of thoughts that Mark started off about enrollment. I think in the long run, we need to develop an enrollment model, ACO. And in fact, CMS could offer a temporary reduction in the Part B premium for enrollment as an incentive to go there. An enrollment model would allow a network approach of lower coinsurance for network providers and higher cost sharing for others. And it's also a way of actually engaging more specialists in the ACO who may not be part of the risk sharing body, but in a sense could have a network relationship with the HMO. I think if you're going to go to an enrollment process, you need to find one which is going to have very low administrative costs. As Mark said, a lot lower than Medicare Advantage. Perhaps just involving attributed beneficiaries with a communication from CMS and one from the ACO they are attributed to of, would you like to enroll? Here are the benefits for you, might be a way of getting into that model. I think I'd want to run the enrollments alongside the attribution model because of concern about the number of years it might take to get a critical mass of enrollees. And I wouldn't want to jeopardize the entire approach in that interim. I think many of the reforms in the direction of patient engagement that involve incentives are going to need reform of Medigap or Medicare supplemental insurance. We know that Medicare raises overall Medicare spending, and that overall reform in that has been overdue for decades. But basically, you cannot work with large proportions of beneficiaries having no point-of-service financial responsibilities. A group I work with at the Bipartisan Policy Center in a 2013 report recommended that Medigap be limited to providing catastrophic protection and needs to leave at least half of the Medicare deductibles and coinsurance uncovered. And this is it's particularly important to design any reform so that Medigap does not cancel network incentives for enrolled ACO beneficiaries. I also have some comments on benchmarks, that the benchmarks we have now are based on provider-specific historical spending. I think it's the right approach to get started with. It's not ideal, but we needed it when we have an essentially voluntary ACO program. Otherwise, Medicare would just have enormous risk selection planned ACO by ACO against it. The uniform national dollar amounts for updating are helpful in blunting the worst shortcomings of this approach, but we're coming up to a critical decision about benchmarks for second ACO contracts. And I think rebasing to the ACO's most recent experience would substantially undermine the business model for ACOs, which was not very strong to start with. I think the long-term path to better benchmarks involves higher payments before higher payments to incent physicians and hospitals and perhaps other providers to work in ACOs. And the Tri-Committee bill to fix SGR really takes this approach when it created APMs, or alternative payment mechanisms, with strong incentives for physicians to get into alternative payment mechanisms. And so if you have some broad incentives to go there, then you can start bringing in community or county-wide experience into your benchmarks with ACOs. And I think ultimately we're just going to have to go in that direction. Let me just talk briefly about some of the opportunities for ACO policy changes. Of course, the immediate focus is on the upcoming rules from CMS, but we should not write off the opportunity of legislative action for bigger changes. We certainly don't have the greatest expectations for Congress addressing critical policy challenges, even where partisan divides are not that pronounced. But we should take note of the far-reaching changes in Medicare physician payment in legislation to fix the SGR that had unanimous support in all three committees of jurisdiction. I think a commitment to payment reform, as seen in the incentives for physicians to participate in alternative payment mechanisms, could perhaps be brought over. Obviously, given the SGR fix, and you're waiving at physicians the opportunities to get into alternative payment mechanisms, you want to make sure those opportunities exist, which really means it should be natural for Congress, if it goes past the lame duck in dealing with the SGR fix, to start thinking about some critical changes in ACOs and bundled payments to really assure that there'll be real opportunities for physicians to engage in alternative payment mechanisms. Thank you.
Paul, thank you very much. And I want to thank the whole panel for, I went through a range of each individually challenging policy issues in introducing this panel. I think you all hit on every single one of them and more: beneficiary engagement, performance measurement, data, reinforcing payment reforms, bonuses for transformation, and better support and evidence on clinical transformation, and other steps as well. We heard from the earlier panels about people who are actually engaged in doing ACO work now, and Joe and Mark you're certainly among them, about how in many ways this is sort of like building the plane out while you're flying it. So there are lots of changes taking place on the fly during care delivery with existing policies in place. But also, what came through from many of these organizations is that they're anticipating things changing, that there is, because of market changes, because of changes in the private sector, payment systems and employers, changes in states, things are going to be changing. Similarly for Medicare, as you all focused on in many of your remarks. And so it seems like on the policy side, there's very much of the same business of, we're sort of building the plane out as we're flying it, that hopefully that refueling will take place in the air when you need it, even if those systems haven't been built yet. We could talk a lot more about the details, but I'd really like to ask you about the sort of the bigger picture of where the planes are flying to. Where are we trying to get? And Mark, you touched on this with your mention of the, sorry, too many Marks on this panel, but Miller touched on this with his description of the long-term vision that MedPAC has laid out, and the bipartisan policy centers had some similar kinds of long-term reform recommendations, Paul, and we've done some of the same work here at Brookings. But let me just ask you all, big picture, 5-10 years from now, where would you like to see our policies collectively get us in terms of supporting the next rounds of ACO reform and implementation, and the next rounds of care transformation? So back to the bigger picture. Yes, there are a lot of important policy details that need to be worked out, but big picture, can you all help with clarity about where we're trying to go?
I think population-based is the key, moving payment that direction. Again, we would have a bias toward the capitation side. I mean, just as some folks are terribly uncomfortable moving away from fee-for-service, when you inject fee-for-service into our system, it screws it up. It's, well, we have to go hunting for, is this going to be paid for or whatever, and we just tell our doctors, ignore it. Most of the organization is paid the other way, and we'll figure this out. So I think population-based payment is key. I think the enrollment idea that's described here is perfect. These members are just old. They're not stupid. And if you don't deserve their business because they would choose to stay with you even after an experimental period, you probably don't deserve the patient. And I think that's one of the things we'd want to create, a set of incentives that make sure that in every market possible, there are competitors. We don't want to be complacent as scientists or physicians or hospitals or health plans or anything else. You want people vying for, I can do that better for you. I would like for you to trust me and help me work with you over your now lifetime of health status, as opposed to just when you're too sick and fall in the door. So those types of things. And then I think the baseline, market baseline, we want progress. So every market in the country has different characteristics. I've spent plenty of time, as some of you know, on each of the coasts. We won't say which one is left and right. But in New York, in the New York area, when I went there in 2004, it was like rolling back the clock 20 years. Whether it was benefit design, whether it was behavioral practices of providers, and the things that are routine in the Los Angeles basin or in the Bay Area are like communistic takeover of the of parts of the greater New York market. Now everybody now is moving that direction, because I think, as was pointed out earlier, the writing's on the wall. This movement is going to change things, so you have to move. But I think having your benchmarks set based on your market, other than national clinical standards. I think there's certain scientific things, but the benchmarks for cost ought to be market-based, and you need to pay for progress. If you ask the actuaries at CMS or Aetna, WellPoint, United, how do they roll up to a trend of 5 versus 7? It's the entire thing moving. You can have 110% loss ratio segments of a plan, and if you improve those to 105, that contributes to those who are operating at 87, and you're making progress on the whole book. So I think let's focus on making progress in some of the gradual stuff that Joe was talking about, but not too slow. If you're too slow, you'll get sweeping government reform that'll be blunt.
Great. I like Mark's model, and you know what we call it the end game, and a lot of our organizations that we work with, their vision of the end game would be to have a population-based contracts with all the major payers in their market, Medicare, Medicaid, all the major commercials. So if I was the CEO of a integrated system that was doing that, I might have 700,000 people that I'm responsible for providing care, and I would have probably a global target of expenditures for each group. And then my bonus might be based on quality, you know, patient satisfaction, engagement, health status improvement, you know, so that's kind of what we see as the end game, but there's some evolution that's going to have to occur, and that's what Mark was talking about, to get there. And we're beginning to see that evolution. It's exciting. We are seeing the formation right now in a number of markets of what I would call multi-owner population health organizations. So this is kind of the latest thing that we're working with, where individual organizations realize that they don't have enough scale, population-wise or capital-wise, to be a really strong population health organization. So they're coming together and forming a multi-owner population health, and I see that as part of the evolution towards this model. So I hope that makes sense.
I think for the commission, I think we've tried to be really clear about specifics in the short run. We're starting to frame up what we think the longer run looks like. So again, I think these are comments that are subject to change as the commission works through them. And again, I think I probably garbled this, but I'll go through it a little bit here. You could view the world as this. You have fee-for-service, and you're probably going to have that for a long time. And by the way, there are parts of the country where fee-for-service is a relatively, in a utilization sense, efficient type of operation. So just keep that in mind. The other end of the continuum right now, you have MA. And MA pays its own claims, markets and enrolls people, and there's a relatively high set of overhead that goes with this. And then on top of that, they get their utilization reductions and they get a profit margin. At the moment, I think the way the commission views ACOs is standing between that. It's an attribution model, but I'll come back to that in just half a second. And its advantage is that it doesn't have that overhead. The claims are paid by CMS. Enrollment is done through attribution, so they're not incurring those costs. So in a sense, maybe they perform well in markets where you don't have very high utilization, but you have some high utilization that an ACO could extract a point or two, and because they don't have the higher overhead, can be a competitive model there. And I think the commission's view is you don't pick a model, you set a payment system that allows whichever model can perform to emerge in a given market, as opposed to saying we should be here or we should be there. And in some markets, those models will be MA, some markets they'll be ACOs, and some markets it may be fee-for-service. Now, there's a whole quality conversation that needs to happen, but for the moment, I'm just going to lay that to the side. Now, attribution, in addition to having the low overhead, has this element to it, which is if you want your patient to stay with you, you have to make them satisfied. In an HMO, they enroll, but they're in there for a year and then they can switch out. But in attribution, they can wander around, and so you have to keep the patient satisfied, and that's an important element of what the attribution model requires. Now, having said all of that, I don't think the commission is inherently against an enrollment-based model, but to the extent it takes on all that overhead and you're enrolling people off the street, why you have an MA program, and one question is why would you replicate that somewhere else? And I think Paul made some important comments of, but wait a minute, if you've been attributed this beneficiary, you've got them for a few years, and they're willing to actively make a decision, that might be a road that could be discussed. And the last thing I'll say is, and he made this point, so I think it's pretty important to keep in mind that you need enough N to make these critical, make them workable models. And if you had a strictly an enrollment model, I'm not sure a lot of ACOs would be able to get enough people in them, at least currently.
Thanks. Well, I think as far as your comment about flying the plane, Mark, it really is, I've sensed, first of all, pretty broad consensus in the delivery system financing and policymakers that fee-for-service should shrink, and that whether it's in Medicare, whether it's Medicare Advantage or ACOs or bundled payments, hopefully will become more important over time. I think the real challenge is getting there is both you have to put out a policy, and then I think the policy process has been appropriately attentive to the experience of those that are engaged in these programs. And so there's a lot of productive discussion about how to change. I think that'll keep going on back and forth. I think probably the biggest challenge is the readiness of different organizations to go different steps of the way towards population health. I just wanted to mention specifically the comment that Joe Zamore just made about the multi-owner accountable care organizations. That's a direction that I hope we see a lot more of, because my concern is that so much in the way of scarce management resources as well as money is going into mega mergers, where I think coming up with multi-owner models can actually accomplish as much, if not more, in improving delivery without getting to those resources and without raising these provider concentration issues in market.
Thank you all very much for the comments, that very broad question. I'd like to open this up to questions from the audience back in the back there.
Hi, Claire Cruz from the Deloitte Center for Health Solutions. A couple of the panelists spoke about specialty physicians, and I was just wondering if you could expand on that, talk about the role currently and where you see that evolving.
Sure, I'd be glad to speak to that. Some specialty physicians like cardiologists, tend to be fairly involved in ACOs, but there are a lot of specialists whose care is not that integral with care management, primary care, that really the ACOs have no reason to engage them. And so this means that you have a lot of the dollars out there really not being part of the ACO. And I think the problem is the need for a network model in ACOs to get the specialists more engaged. And I mentioned that I think some political needs of providing opportunities for specialists to be involved in ACOs could happen with the SGR fix that we've seen.
Other comments on this? Yeah.
Yeah, I think one of the things that presents this evolution is big challenges for the organizations that have absorbed a lot of them. So if you're a big multi-specialty group or a hospital system that, because of the way the system worked, your incentives were to collect these providers and make sure that you enabled them to do as much as they could for everybody that they thought they needed it. I'll be polite about that. This is very different. Hospital systems in particular that are going to move into accepting risk, all of a sudden, how long can they afford the subsidization of the losses they take on the big physician purchases they've made? They're very open about that. The model has changed. So, your estimates, maybe you sold bonds 3 years ago. Your estimates of, how many admissions, how many stents are you going to put in, how many whatever that's fueling your system currently, it changes if you implement every best practice that we know of. Now, we know that takes time, but it's a big economic issue in terms of how do you change the system, take that cost out, and make room for the very best providers to still be able to participate.
Two things I'm seeing. One is in one large organization, they've decided to develop models for 3 different groups of physicians. One is the primary care, and then the specialists who are subspecialists that are really hospital-focused or inpatient-focused. And then there's the hybrid group in the middle, endocrinologists, cardiologists, who really do both. And so they're looking at models for that hybrid group of cardiologists, endocrinologists, nephrologists, to involve them more in managing their primary care load. The second model that we've been working on with another organization is what I would call an episode of care model within an MSSP. So this is an MSSP that's been successful, and they want to further engage specialists in the MSSP. So they've designed an episode of care program within the MSSP for cardiologists, orthopedists, and to look at setting a target with that episode of care and then sharing savings among the MSSP and with those specialists. So that's a model to further engage specialists that maybe have not been as engaged in the past. So those are a couple of models that we're seeing evolve in markets across the country.
Joe, for those second types of models, the ones involving specialists that are handling kind of more discrete, specialized aspects of care as opposed to the cardiologists and the endocrinologists who are very much involved in things like coronary artery disease management, heart failure management, diabetes management, things that are part and parcel of the population-based ACO performance models. Are there some other quality measures that need to be developed in this area too? As you're thinking about conditions like cancer, rheumatoid arthritis, hepatitis C that are just not well covered. And then I want to go back to Mark's point, and the point that a lot of ACOs have emphasized is that, look, the measurement and reporting burdens are too high now. So how do you reconcile that?
And so a lot of places are, and I would imagine most people in the audience are familiar with choosing wisely. And so we're seeing the adoption of choosing wisely for appropriateness in in specialty and subspecialty areas, in large clinically integrated networks and ACOs. So that's a way to, I think appropriateness is coming into play in those subspecialty areas as one area. And I'll turn to Mark to comment on
Well, one of the things that I was thinking about in particular, I got to get this out before I forget, is as we experiment with sort of global case payments and packaging everything up, with respect to specialists, we may want to be careful how much we lock that in. So if it ends up in a law or a regulation that's so strongly defined you can't get out of it, I mean, some of the science is moving rapidly. So the same cardiologist that you trusted to manage this big case, all of a sudden they're going to be using an entirely different type of approach that doesn't involve the hospital, doesn't involve interventional procedures, involves other kinds of genomic-based kinds of treatments, and it's going to eradicate it. So I'm sorry, but your follow-up question, because I was thinking about.
That makes sense, but this was, I guess maybe I can put this to Mark about the measurement issues related to these areas of specialty care, orthopedics, cancer, rheumatoid arthritis, and so forth that are not well covered in the full population ACO performance measures.
I know, and this is really nerve-wracking with all these marks up here. I keep this rack sitting up there. So a couple things that the Commission has said in reacting to these comments. I think the Commission's comments in its letter about the notion of letting ACO designate certain specialists as attribution nodes is directly consistent with what Joe was saying for his first model. There are certain specialists that are really more about the continuum of care and the coordination of care. And this wouldn't be all specialists, but there is probably a set that immediately rise to most people's minds where you'd say that's logical. Now that was driven by some technical problem that was being created by a second stage specialty assignment, but that's not worth mentioning here. So I would say our views are very consistent with your first model. To your point, Mark, on quality, I think there is real concern, and this concern is not just in the ACO space, but fee-for-service and elsewhere, that if we say, okay, well, anytime we bring a specialist in or bring in some other provider, we got to develop a specific set of measures. And I know that there are disagreements on this point, where a lot of people say you have to be able to measure my thing and my thing well. At least at this point, the Commission's view is, from a payment perspective, the view is more of a population-based small set of quality measures that money can be awarded or not, as the case may be, whether you're an MA plan or an ACO plan or whatever the case may be. And then the responsible organization can decide which metrics internally it wants to use to chase its particular model around, as opposed to a single set of measures, all for all, that type of thing. And very great concern on the part of the Commission that we're kind of overbuilding on the individual measures. So we have something of a different view there. The other thing I would say to this, Mark, okay, so just Is I almost thought you were making this point, and if you weren't, then you can disassociate yourself. I think you have to be very careful about building episodes around specialty care because of what he said. And I think sometimes there's some specialty groups are kind of waking up to this process and starting to enter and say, okay, you need to build an episode around my care. And I think in some ways they see that as a way to preserve what they're getting currently. And I think we should all pay attention to that comment, which Mark's comment, because I think those processes could be changing, and we should think very carefully about how episodes are constructed.
Yes, that was the point, yeah.
Great.
Well
Paul?
said.
I just want to say something about the quality for specialty care. That I think what Mark Miller sketched out was probably fairly practical, but I don't want to give up on the fact that often specialty-specific measures are much stronger as far as outcome measures of quality than the general measures for a population. I was influenced by studying the CalPERS experience with joint replacement reference pricing. And you know, if you look at the very specific quality measures they have for joint replacements, you know, they seem to me to be much, much stronger than many of the general quality measures that you would tag, say, for an entire hospital. So I think it's worth thinking about some very strong quality measures that may only apply to a very important frequent procedure and working that into the system at some point.
We have time for maybe one more back here.
Hi, I'm Mara McDermott from CAPG. You guys have all spoken about different changes to the ACO program, and I was wondering if you could speak a little bit about to what extent you think legislation is needed to make those changes versus what CMS or the Innovation Center could do to advance the next generation of ACOs.
I know why everybody's
I think
pointing at Mark, Mark. But
I think number one, since along with a lot of people, I was going around talking to both sides of everything. I think getting the SGR fix done, it is right-minded, it's headed in the right direction. We have to get comfortable that some providers should get more money than others because they are demonstrating participation in an organized system that's supposed to do better things for consumers. So we need to get comfortable with that. I think that, you know, I believe it takes legislation to solve the payment changes that are going to go off the cliff if we don't, you know, reset how things are paid in the baseline information. So I think you do have to have that. Otherwise, people who will identify we should change, but they won't have the legal authority to, from a regulatory standpoint, make a change.
Other thoughts on the legislative outlook?
Well, I don't know about the legislative outlook, but I think a lot of the recommendations that we made in the June letter can be achieved regulatorily, although there are things that clearly require legislation. We tried to point that out as we go. And then I would also say that, particularly thinking about the future and going forward, there probably is a legislative change that needs to go along with this. And it's always clear if the Congress says these are the changes I want, that, you know, the Secretary will then be much more likely to take those undertake those changes.
Any final comments from the panel? I'd like to thank all of you for an excellent and wide-ranging discussion about ACO policy issues and solutions. Thanks for covering the short term and the long term.
Thank you. I always enjoy listening to you.
All right, we are about done. I want to thank all of our speakers today and all of you for participating in today's event. We look forward to working with you on these issues in the future. Obviously, accountable care and the ACO experience is a work in progress with some notable results on quality, some important successes on costs in Medicare, in Medicaid, in private and employer kinds of plans, but obviously a lot more work to to do. We've talked about some of the research on what can succeed in terms of care transformation and public policies to support it. We've talked about some of the policy steps that can help people who are trying to engage in care reform on the ground, both provider organizations and patients and consumers and their families, do that more effectively, but there's obviously more to come. Just want to also give a quick thanks to our ACO Learning Network, which made much of this event possible, both in terms of the technical expertise, the contacts with many of the experts around the country and people who are actually engaged in ACO activities, and help putting this all together. We have more information available on our ACO Learning Network for those of you who are interested, and that's the contact information for it. The Brookings ACO Learning Network is aco@brookings.edu. For right now, though, I want to thank you all very much for attending, and thank you for your concerns about improving the quality and addressing the cost of health care in the United States. Have a good rest of the day.